Oh, good, I do have it here. So the third thing about looking through the patient's eyes and seeing what they see, central vision, peripheral vision, is ocular motility. So not only can they see centrally and peripherally, but they can move their eyes. So you want to test all three of those things. So again, first question, what do the eyes look like from the outside? Limbus to lid, limbus to canthi, pupil, size, shape, and equality. Then you want to move to what do the eyes look like if I were to jump in their head and look through the eyes. And we have central vision, peripheral vision, and ocular motility. And ocular motility, we're basically using those. You don't have to use the 6 cardinal fields of gaze, you just have to get them into the 6 cardinal fields. So if you don't want to go center, this way, that way, you can just go around if you want, or you can go, it doesn't matter how you do it, as long as you get their eyes to move into each of those quadrants that we were just testing, or in this case, there's 6 fields. Sometimes when a patient looks down, I'm going to try and get my head, you go with the camera, look down, you can't see their eyes. So sometimes you just have to take your fingers and elevate. If you do it too hard, they'll start to see double. So you have to be careful. One of the things about this test is any time in those cardinal fields, remember what I said earlier, a millimeter or 2 of ocular deviation causes double vision. So do you think looking at a person's eyes, looking at your fingers, you're going to see a millimeter or 2 of deviation? Probably not. You're going to see massive deviation, but the patient's going to start seeing double way before you're going to notice that their eyes are not malaligned. So when you're doing the test, just say to them, at any time you see double, I need you to tell me right away. And then when they see double, we do what I said earlier. You try and find which direction does the double vision move further apart. And you find the direction it moves further apart, and then you go back to say, okay, well, if it's down and in, it's the trochlear. If there's no ptosis, no core meiosis, it's not the third nerve. And if they can't go laterally, it's probably the 6th. Anything else, it is the 3rd. So not all that difficult. It's one of the things that, there's a lot of things in neurology that really take a lot to get your head around, and that's not one of them. Yet, it seems to freak a lot of people out, because I think the way that it's taught is to try and remember the action or and innervation of each of the extraocular muscles. All right, so finally we test accommodation, and here's where you come in and you look for convergence as well as constriction of the pupil. Convergence of the eyes, constriction of the pupil is accommodation. The third thing is the focusing. The ciliary muscles from the parasympathetics from Edinger-Westphal are going to control the thickness of the lens. So you also accommodate in focusing, but you really can't see what they're seeing, so you can't tell if it's in focus or not. So convergence, pupillar constriction, and thickening of the lens. Convergence is accomplished by the medial recti muscles and is dependent on cranial nerve function. Constriction, of course, parasympathetic fibers. So when we do the extraocular motility test, we're looking for full and concomitant movement of the eyes. Also, we're looking for nystagmus. Is there any nystagmus when we do that? It's essential that the patient report any diplopia that they see right away. If you do detect an ocular deviation, note whether or not the movement is the same in both eyes. Now here's what we're saying there. I'm going to again give you a quick talk, and then the text will come in later. There's a question popped up, what is accommodation spasm? The only thing, I haven't heard that term used, but it sounds like that. Like just the eyes go into an accommodation position, which is medially deviated bilaterally, and hold in that position. That sometimes, by the way, is indicative of somatoform disorder. I think we even covered that yesterday. Convergent spasm, we call it, not accommodation spasm. But that is a sign, because that's something people can do. It makes their face look really weird, and it's sometimes, sure, you're welcome, Jason, sometimes related to a somatoform disorder. Yes, older folks do seem to have more nystagmus, particularly at the end motion. Absolutely they do. They also have these pinpoint pupils that are really hard to see. And it's the only thing I like about pediatric neurology, because I don't even do I don't really like kids that much. My kids are okay here and there. But I'm not a pediatric neurologist, so my practice is really adult neurology. But when I look in people's eyes, that's when I wish I was a pediatric neurologist, because kids' eyes are just so easy to see. And now, there's 2 types of ocular deviation, concomitant and non-concomitant. This is very, very simple. If the eyes are deviated, Okay, so we have a right exotropia. But no matter where we go with ocular motility, the deviation stays exactly the same. Then we call it a concomitant heterotropia. So the eyes are moving concomitantly. It's just English language. However, what's the significance? Well, it means there's no paralysis. Because if the eyes were paralyzed, the extraocular muscles were paralyzed, we would find that when we moved into the paralytic action of the paralytic muscle, that the eyes did not move concomitantly. So, non-concomitant movement of the eyes is always paralytic, and concomitant movement of the eyes is always non-paralytic. And I said always there, and you know that in healthcare there's never really an always, but as a good, solid general rule. Now, why would a person have ocular deviation but without paralysis? And the answer to that is, it could be just a congenital thing. But sometimes what happens is, you know your macula central vision. So let's say one day you're playing sun stare with your older brother. Some of you may know that Regan guy, he has a little comedy sketch on this. But he says him and his brother are playing sun stare and I won. Meaning he can stare at the sun longer before he has to look away. Well, you can damage your macula. They call that solar retinitis. So you can actually burn your retina by looking at the sun. What part of the retina do you burn? Your macula, because you're looking at the sun, so it burns that spot. So what happens then is your brain finds a new macula. So what it'll do is, again, it's plasticity. Remember, the retina is brain tissue. Brain tissue is plastic, meaning it can change when it needs to. So what it'll do is say, oh, every time I beam light right onto that spot of the retina, it's a dead spot. So I'm going to try beaming light next to it, and it'll take your eye and it'll just creak it out until it finds good, usable retina, and then that's your new macula. But now you've got non-concomitant eyes. So the central nervous system is wonderful in how it resolves these things. And so in that case, you'd have a non-paralytic heterotropia. Now, nystagmus is defined as a rapid to and fro oscillation of the eye. We talk about physiologic, or as Marco mentioned there, and I'm not using last names just as I don't know, these days everything's so private, but the NSA is probably recording this, so you can find out later. But if you have this involuntary jerking of the eye, and this would be a lateral, okay? This would be a vertical, and you can even have rotary nystagmus. I actually found online, because LASIK surgery is so big, a ton of close-ups of eyes undergoing different kinds of nystagmus. I put a couple in here. But with the internet, what it is these days, people, you can go and see these conditions as many as you want. Just type it in and go to the images or videos, and it's unbelievable how much information is out there for us these days. So, as I mentioned, when the nystagmus is endpoint, probably non-significant. But when it starts right in the midline, or before the sclera touches, is obliterated, and the limbus touches the canthus, when you're moving laterally, if you see it there, that might be pathologic. Nystagmus can be completely benign, and some people are born with congenital nystagmus. Some cases of congenital nystagmus aren't so bad, and some are terrible. The patient is really virtually blind. They have what I like to call the Coke bottle glasses, where they just have those big, thick glasses. Now, nystagmus, when it's not congenital, when it's associated with vertigo, vomiting, ataxia, that's sort of different. So, nystagmus, we can grade it and we can put some names on it to give another physician an idea of what we're seeing. So, if the nystagmus has a quick component and a slow component, and I'm exaggerating, you really got to stare at it for a while. You'll see when I show you the video. I'll ask you at the end which is the quick component, and you'll probably, half of you will get it different than the other half. But if you look real closely, you'll see that there's a saccadic eye movement, a jerk, followed by a coming back at a slightly slower pace. But it looks more, it all happens a lot quicker than I'm doing it with my hands there. So if there is the fast side, we call that a jerk. So we'll call it jerk nystagmus. Now there's some where there is no jerking. And so a jerk nystagmus is the most common by far, but without it, without jerk, you can just call it a pendular nystagmus, meaning like a pendulum, the eyes go back and forth at the same speed. You occasionally can get one eye with nystagmus, and anytime you see really bizarre stuff, like one eye's going up and the other eye's going to the left and down, and It's almost like the two eyes are disconnected. It's probably internuclear ophthalmoplegia, that yoking mechanism. And again, there's a lot of videos on this. In the full program that I do, there's a couple more videos of patients that have this. But like I say, it's so available to you to find. Also, we then talk about the nystagmus as either jerk or pendular, but we also want to know which way it's going. So the most common is horizontal jerk nystagmus. That's the one we see most commonly. If you see rotary nystagmus, vertical nystagmus, you're probably dealing with, again, these internuclear ophthalmoplegias. Oh, good. See if it works. So this is a horizontal nystagmus, and I have it labeled so I can't ask you which side. Come on, baby. Doesn't look good, people. Too bad. Okay? Maybe the next one will. Yeah. Yeah, there we go. That's working. So you can see there that there's a jerk and then a slightly slower movement. This one's a little tough, but I would say it's jerking to the patient's right and then coming back. This is a really tough one, actually, but you see how it's, so that's the nystagmus. So what happens is, imagine trying to do LASIK. You see that little red cross in the middle? The computer is trying to find the center of the pupil. And the eye just won't keep still. I don't know how they do LASIK surgery on people with nystagmus. Imagine trying to shave off that guy's cornea. Okay, that worked. It's always nice when things work. Every once in a while they do. Okay, here's a couple of videos to just sort of show what this whole exam is going to look like from the outside. I want you to just look at my fingers, all right? Just watch my fingers. Don't move your head. Now, any time you see double, you see two fingers, besides I'm holding up two, but I mean double.
No.
So 4 fingers, that all looks okay. Okay. Next one here. The reason I put my finger under her chin, there's nothing special with that, except people always want to move their head. So if you just touch under their chin, then they stop moving their head and they only move their eyes. So yeah, looking right here, now switch to my finger. I'm going to put one finger here. Just watch it go that way. Watch it go that way. Now if at any time you develop double vision while you're doing this, let me know. It's always really bad when you look at a video that's 10 years old and I'm wearing the same outfit. So finally, ophthalmoscopy. What do the eyes look like on the inside? Well, guess what, people? All right, so the next test we're going to talk about, the corneal light reflection, is a fabulous test. It really can totally replace everything I talked about for the last hour on ocular alignment because it's such a good, accurate way to do this. So basically, here's what happened. Normally, you're sitting doing a history, you look at the patient's eyes, limbus to lid, limbus to canthi, pupil size, shape, or quality, all looks good to you, you move on. Even if they have headaches as their complaint. But, on the other hand, if you see something that just doesn't look right, maybe they have an epicanthal fold, maybe you think that there's a little more sclera on one side than the other, then you can do a test called the corneal light reflection. Be careful because there's a corneal light reflex. There's a corneal reflex, but this has nothing to do with a reflex. There's no sensory, synapse, and motor arc. There's just a reflection of light, just like the red reflex. It's one of the things in neurology that I hate, these misnomers, that it's not a reflex. In order to have a reflex, you have a sensory, you have a stimulus, which is picked up by a sensory neuron, at least one synapse, a motor neuron, and an effector. That's a reflex. In any event, what you do is you take your ophthalmoscope and you put the large light aperture, and you move back until you can see that your light is covering both their eyes. And I have a video of a patient with this. You tell them to look straight ahead in the distance, and then you look at their cornea, and you take a look at where the dot of light from your ophthalmoscope is reflected. And if that dot is in exactly the same part of both eyes, slightly medial to the center, there's no ocular deviation. But if they're looking straight ahead and you see the dot is on a little different part of the cornea on one eye than the other, then there is ocular deviation. Now, if the ocular deviation only occurs during ocular motility, you can then you don't move the light, but you can actually put your hand on their head and start turning their head through the 6 cardinal fields of gaze while they stare at the light. And what happens is, ultimately, it's exactly the same thing. They're still using those extraocular muscles. Then you'll ask them, at any point do you see 2 bits of light? And when you move into the weakness, the 2 little dots of light get further apart. Now, the case that I have here coming up is an 83-year-old guy. I was out in New York teaching the class, and this guy brought his dad in as a patient, and he had about a 4-day history of double vision. It's a long, it's actually virtually all these cases are posted online at ChiroClasses.com. So if you ever see something in here and you want to watch the whole case, you can actually watch the entire soup to nuts, interview all the way through to report is usually how we do those. The report that would go back to the doctor who referred the patient. But for this particular test, the patient that you're about to see had a little bit more complicated. But what you will notice is ptosis, and also this was a very early attempt at me to do video. And when I rendered the video, I rendered it at a speed the computer couldn't handle, so the audio got separated from the video. You've probably seen a little bit of that in some of the other ones, but this is the worst of the group. So don't worry too much about what you're seeing here, except I'll try and stop this and get you at the correct side. Let me make sure I'm not missing something in the text here. Yeah, this is just a description, but again, picture's worth 1,000 words, so let's just take a look. I hope I didn't delete him, though. I may have, because I watched it and I was thinking this might be too complicated to discuss. By the way, this is what it would look like in a graphic. So here you're holding your ophthalmoscope, you're making sure that the aperture is large enough to cover both eyes, and then you're looking at the cornea in each eye to see where the little tiny dot, which is a reflection, the corneal light reflection. And then you can just put your hand on their forehead and move their head in a way that causes their eyes to go through the 6 cardinal fields of gaze. Oh, I did leave it in. So this is, I forgot his name, he's a very sweet old guy. But take a look right here, before I even turned it on. This is a guy, 82, 83-year-old male with about a 3-4 day history of sudden onset of double vision. What do you see right away?
Luminaire problem.
Right, he's got ptosis, very good. Our doc's here, yep, and a couple of the docs online. He's got ptosis. So anybody comes in with that, and his ptosis is clear because it's covering part of his pupil. So when you see that, you know third nerve is not normal. There's definitely something wrong with this guy's third nerve, right, to start, and that would account for his double vision. Now I want you to look right at that light. Okay, what I'm going to do, I'm keeping this light in your eyes here, is I'm just going to move your head a little bit. I want you to tip your head back. Now, anytime, do you see 2 lights right now?
Yeah.
Okay. Tell me anytime the 2 lights get further apart from each other. Now bring your chin down.
They're moving, but they got close to each other just now.
Okay, good. Bring it down even further. Okay. Now turn this to that.
One light is further away from the other one. It's in this, over this way.
Okay. And let's go this way.
And it's further away from each other when it's down.
Okay. Just a little different. This time I want you to keep your head still and look at my fingers. And also the whole time you hear me asking, do you see 2 dots? Yes. Oh, now they're getting closer. Now they're getting further. So while I'm not going to go all the way and figure this out with you, we don't have time. You can see how by moving the patient's head into the direction of the action of the paralyzed muscle, you're going to cause the dots to get further apart. And when you move their head in such a way that you cause the eyes to move away from the paralyzed muscle, then the dots are going to come closer together. And we talked about this, how light introduced in the pupil of one eye is always going to cause in normal circumstances, will always cause both pupils to constrict symmetrically and evenly. And it's a little difficult because, like I said yesterday, you have to be shining a light in an eye and looking at the other eye. So you can't be looking where you're shining the light. And with your ophthalmoscope, it's a very directed beam. It's not a sloppy beam like a cheap pen light. And so if you might miss. So you have to be careful in doing that. But otherwise, it's a really simple thing to do. And so here's the look of the eye light reflexes. And by the way, in my clinic, what I tend to do is shut off the lights in the room. But then because there's no windows, it would be pretty dark. So I turn on the X-ray view box. That's why this mood lighting.
Have you just look right there and see, okay?
I'm trying to shade her eyes again from the room light, the ambient light. So there's direct, away, consensual, looking at her direct, and now I'm looking at her other eye, consensual. That was hard. We talked about swinging flashlights, so we're going to move through this pretty quickly. In fact, I think we talked about it yesterday and today. And that is, of course, then the Marcus gun phenomenon. So I won't even reiterate here except to say that there really is never a situation where you shine a light in someone's eye and the pupil dilates. The only thing that you're going to get is a pupil that's constricted because the light's in the other eye, that then constricts to a lesser degree so it appears to dilate when you put your light in it. We talked right out of the chute yesterday about the red reflex and how much I hate that term because it's not a reflex and it's not red. So that's a great name for it. And again, what that is you hold your ophthalmoscope, you're further away from the patient, you use it just to shoot a light. It's like you're doing the cat's eye test. That's what I would call it. So when you look at a cat and their eyes reflect, imagine if you looked at a cat, the eyes reflect, there was a black spot in it. Well, the black spot in the reflection is an opacity, and that's really what you're looking for in the red reflex. It's just a way to shine a light, have the eye mirror the light back at you, and see if anywhere in that pathway there's something that's opaque. Opaque, of course, meaning it will not allow light to go through it. And I talked about you wearing your contacts, and the patients with tinted contacts, they have to come out. A lot of these are probably from the same slides as in the ophthalmoscopy lecture. So we've already covered that. I want to go straight really to the fundoscopy part. So here's what fundoscopy might just look like. I'll just do these videos. But again, you probably see it's going to be, first of all, I'm checking the aperture, making sure I'm at 0 diopters. I've got right hand, right eye, patient's right eye, and my left hand is on her head. I'm coming in for the red reflex. And you're going to go like a keyhole. You can get real close. I'm holding my breath. I'm also using my left hand to steady her head and elevate her eyebrow. So I've got my thumb on her eyebrow and I'm pushing up to hold that upper lid up as much as possible, keep her from blinking. Now I'm using my diopter wheel to focus on something specifically, and then we switch sides.